Good evening, everyone present here. I am Faraz from Clarinet. Clarinet is very proud to be a part of this session as a digital partner. Clarinet is India's largest live digital CME and doctor-generated learning platform. With all of you, I am presenting a short video on Clarinet. Thank you so much all doctors for watching the video. You all are requested to visit our website www.clarinet.com, where you can watch lots of live sessions conducted by expert doctors across the globe. And we have MedWiki service, that is medical Wikipedia for doctors only, that you can also read. By taking not much time, I would like to hand over this session to Dr. Amrit Gupta ma'am, Treasurer Lucknow Menopause Society. Over to you ma'am, kindly proceed from here.
Amrit ma'am, please unmute yourself.
Sorry, I am unmuted. Good evening to everyone. I welcome you all to this session, this prestigious session, presidential program. And to start this program, we start first of all with the and I would request Mr. Faraz to play the Saraswati Vandana. Arogyam dhana sampada shubham kurutvam kalyanam arogyam dhana sampada shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam arogyam dhana sampada shubham kurutvam kalyanam arogyam dhana sampada. So bowing to Goddess Saraswati, now we start our program, and I would request our president of Lucknow Menopause Society, Yashodhara madam. I think she is logged off though.
No, she's there. She's there. She's joined back. Yes.
Okay. Yashodhara ma'am, I request you to give the welcome address for this session.
Good morning, good evening, everybody. I'm sure Pushpa has joined.
Yes, ma'am, she's joined. She's here.
Thank you. So welcome all. Especially, I would like to thank you, Dr. Shobna, for giving the opportunity to Lucknow Menopause Society for organizing the President webinar. And really, this webinar on every Tuesday, we look forward for these webinars. Dr. Shobna, President IMS, has done a wonderful job, and she's doing it. And we, very learned person, in fact, I will say. So welcome, Dr. Shobna. Our chief guest, Dr. Pushpa Sethi, who is a president-elect. And all of you are my friend, but I have got a different this thing with Pushpa also. Dr. Pushpa Sethi, we met when I was I do not know, chairperson family welfare committee, and I so welcome Pushpa, very active. Now she is going to be present. Let's look forward what she is going to do. So going through I don't think so I have to read the whole CV. Pushpa, do you want I have to read it?
No, not at all. Just one.
Because then we lose time for this thing, because we all know each other very well for a long time.
Yeah.
So, but I said you are a president-elect, so you are coming as a next president IMS, and I feel very proud of you. So, Pushpa, may I welcome you for giving your some pearls of wisdom to the audience and to me also.
Thank you so much, Dr. Yashodhara. And let me at the outset big hello. I was not able to say. I think I logged in just a few minutes late. A very good evening to our president, Dr. Shobna, our immediate past president, Dr. Ambuja, Dr. Yashodhara, Dr. Asna, and so many of you. I cannot just name everybody, but all my dear friends of Lucknow Menopause Society, a very warm welcome. I mean, a very warm thank you to all of you for having me here as the chief guest. And these presidential webinars on every Tuesday, Shobna, I think this is excellent way of imparting knowledge, taking up a different subject every time, and these are really you can listen to whatever subject you are interested in. You look forward, you know that 2 hours on every Tuesday are assigned to the webinars, and every society gets a chance whoever wants to do it. And this is really one of the best things that could have been done, because menopause society means not only a research about the midlife health of women, but also imparting this knowledge to all our society members, to all the new societies that are forming. And it's very heartening to know how much interest now even the youngsters are having in this subject. I was extremely surprised when I appeared for the CIP exam, being a lazy person, wanting to appear every year and just not being able to. This year I said, no, I must go in for it. And I was really taken aback by the interest the youngsters had in the subject. And this is only because we have been able to spread the knowledge. If the knowledge is not spread, it's just the subject maybe will not interest the younger generation, but it has really taken on very well. And so thanks to all of you, all our seniors, all our past presidents who have done so much work in this. And so this has been my area of interest, the society which really I found so much encouragement from, so much I felt at home, and the subject was of so much interest. And I also promise to do, when I come up, whatever I can to do the best to take the society to higher grounds. And congratulations to Lucknow Menopause Society. And the topics today are really very nice, wherein tumors, wherein this thing is it's a subject that we all need to know more about, I think. And the speakers are excellent, and I'm just looking forward to all the talks and the panel discussions today. Congratulations, Lucknow Menopause Society again, and congratulations, Dr. Shobna, for taking up this very excellent Tuesday webinars.
Thank you, Pushpa. Thanks for coming and being nicely talking about all this. Really, I think you'll have many societies left for your year also, because we can't cover all the societies this year. You can have either Tuesdays or Wednesdays or something else. Yeah.
Absolutely, definitely. Yeah.
Thank you so much, ma'am, for your wisdom. And now it's my proud privilege to introduce our guest of honor, Dr. Ambuja. We know her very well, and Ambuja ma'am has been ideal for me also, and for so many of us. She was the past president, and she has really instilled so much of enthusiasm in the menopausal society that definitely we are going to have her in our minds always. She is the retired professor, HOD in Osmania Medical College, Hyderabad. And basically, she's an inspiration to us. Ma'am, please go. Ma'am, we would like to have some words of advice and some pearls of wisdom from you too.
Mr. Faraz, please stop sharing. Thank you. Yes, Ambuja ma'am.
Good evening to all my friends. And all, Lucknow is very close to my heart.
Yes, ma'am.
And so is Yashodhara. Though she is not in Lucknow, always Lucknow means the first figure that comes into our mind is Yashodhara.
Thank you. Thank you.
All Asna, Bipasa, all, everybody, I'll tell you. Pushpa Sati, to name, because any webinar comes to, we are so excited to see all the faces of our friends again and again. Second, the webinars, I'll tell you, so exciting. We are waiting for the Tuesdays to come. So that all new topics we are hearing and repeating the topics where we get to know about the latest things that are happening. As it is today's topic, I'll tell you, it is so good and so important for us. Because, what I observed recently is number of doctors are increasing. Even if you take AP, there are 16 new medical colleges have started. So those doctors every year, so many people are going to add on like that in all the states. And everybody's interest is either in endoscopy or in ultrasound. Those are the fetching topics, they are there. So it is like this because of the latest machines what are there. We are able to see even 2 centimeters ovarian cyst. And everybody, starting from the childhood to the old age, the first investigation, you can say without investigation, the first stop that comes to any person is they will write ultrasound. They'll go and get the ultrasound, and the specialist gives 2 centimeters ovarian cyst in the right ovary with bold letters and underlines. So the next step is from RMP, where they will land with the surgeon. They will never come to the gynecologist. So the next stop is immediately next day they will be posted with minimal investigation. They will post them for the laparoscopy. So what happens? Either he will remove
No, that is too much.
enough, or they will remove the ovaries. That's what is the
No,
thing that's
no,
happening.
don't reload.
Yeah, it is happening. They will never come to gynecologists. We
Oh
are
my
the people
God.
who are going to decide what to do, what not to do. But really, what is happening outside? Maybe in the
My
cities
God,
they will come to
terrible.
us, but they don't come. Well, I'll tell you why it is. A 18 years girl, she was with amenorrhea, and she went for ultrasound. They gave as a bilateral ovarian cyst, big ovarian cyst. 18 years. So the next step was they wanted to do the laparotomy bar laparoscopy. They came running because I was in Usmania Medical College that time. It is a general hospital. They referred her because a blanket rule was there from the superintendent. Without the consent of the gynecologist, case should not be posted. So she landed with me. When I did the investigations, thyroid was 100 TSH. This is because of the thyroid that is there. I told them very clearly, don't go for laparoscopy or laparotomy. This is the thyroid that producing the ovarian cyst for you. So with 3 months of treatment, it's the size enormously, it has come down. 6 months of treatment, she became normal. So what is more, the moral of the story, what we have to learn is first do the clinical estimation because the patient was short and thick skin. These things, no, we learned as MBBS. At least we should utilize all those things, and then only we'll send them for the
One panel question is
examination.
over.
That's what is happening. And who is going to teach the RMP doctors? As n number of doctors are increasing and double n number of RMPs are increasing. So God only should save us from all these things. And we ourselves are talking each other how to do this and that. Who will give this message to those RMPs, which is the first line of filtration for any of the people, except very few. Even in big cities, the first time they'll go only to they will search for the RMPs. You know,
There are no
have got
RMPs
very
in
big clinics, middle of the city. How come they are able to do it? And their OP will be full always. They will see per day 100 cases. To see for 20 cases, we are tired by the time it is there. And they will see 100 cases. This is what is happening. So I feel awareness should come to all the fields of people, not only the gynecologists. We will learn, but I think it should spread the news to all the fields, and everybody should know when not to operate.
You,
That's what is more important.
for your real words of wisdom. Real
Thank
words.
you. So with
Thank you
this,
so
I
much.
thank
Thank you so much.
Dr. Shobana and all the executive committee for giving me the opportunity to
And welcome to this thing that you have come and joined.
Thank you
That's
very
the
much.
best.
Thank you.
Thank you so much, ma'am, for your pearls of wisdom. And definitely, it is so important to know when not to operate. And that is the
Yes.
thing that we really need to spread the awareness about it to all, as many as possible. Now, next on the line is our dear Dr. Vipasa Sen, and she is the treasurer Indian Menopause Society for our session, and she has been in various positions in the Indian Menopause Society earlier also.
Okay, that's
And I would request her to say a few words to us.
Good evening, my friends from all over India, and good morning to Jashodhara. Of course, really, this is a boon of the pandemic that we have started connecting with each other so frequently, and we can concentrate on academics without wasting much time in traveling and other things. So academics has now increased, and I thank Shobana first of all for masterminding this Tuesday presidential webinar series. And the topics are really nice, and I really enjoy the week before last Tuesday I was in Bhopal. Now I am in Lucknow. God knows next week where I will be again. So this in between, okay, I will be physically present at Jaipur. That's so true. So really I enjoy these things, and this because of this webinar we can connect with each other and concentrate on academics. That is the thing, and I thank Asna for inviting me, including me in this Lucknow program.
You're
So
most welcome, Vipasha.
yeah, actually I am eager to listen to all of the topics are so interesting. Without wasting much time in talking, I am eager to listen to all those things what is said today. So I wish all the success of today's webinar, and here I stop. I am waiting to listen to all of you. Thank you.
Thank you, ma'am. And
welcome, Dr. Reena.
Well,
joined at that time. I was busy in sharing a screen.
Thank you. Thank you.
Because I said we should now unite in the UP. So
Mr. Faraz, please share the series of the chairpersons.
So next, now we start our scientific session, and I'm happy to introduce Dr. Anju Soni.
Hi, Anju.
Who has been President Jobs and President of Jaipur Menopause Society, and she has been a very active.
I think Anju ma'am has not joined yet.
Yeah, that is what I am also thinking, that she has
yes,
not.
Yes.
Okay, you could call the next chair.
Also, Dr. Uma Gupta, has she joined? No. Well,
no, she's not joined.
Then we'll just start with the top.
Ask Dr. Reena Srivastava to join this session also.
Yes.
So I invite Reena Srivastava ma'am to.
Seema is there?
Yes, Dr. Seema has joined. Yes.
So welcome Seema, and make this thing. Dr. Reena Srivastava and Dr. Seema for this session, the chairperson.
Yeah, I welcome you to be the chairpersons of this session. And this is our presidential talk, and I hand over the mic to you. I hope to introduce Dr. Shobana and Dr. Seema and Dr. Reena Srivastava, ma'am.
Thank you, Amrit. Can I have CV of dear
Shobana? No, you just don't have to introduce with CV.
Definitely, you don't need any introduction. You're president and everybody knows you for long and long serving in Menopause Society. And she always chooses the topics that are so very useful for everybody and gives a very clear concept of the topic. So I welcome Dr. Shobana for her lecture.
Thank you, Dr. Reena. We have got fibroids in Gorakhpur, I think, no? Today morning we had a discussion, so we're looking forward to an good talk on that. So this is laparoscopy in suspected ovarian malignancy, in ovarian tumors is what Asna has told me, but this title was given in, had gone to Orissa. You know, it's like tightrope walking. You know, it's very walkable, it's very safe, but then it's very scary, like that glass bridge. You think you'll fall, you'll think you'll fall, you think you'll fall, but you really won't fall. It is quite safe, laparoscopy in ovarian malignancy. But the questions that are raised are, is it safe for undiagnosed cases? Is it adequate for diagnosed cases? Is it preferred for inoperable cases? And is it preferred for no other cases? So these are the questions to be answered. In olden times, when such a huge mucinous adenoma was there, they used to do a laparoscopy. And then they used to keep their trophies on the table and take photos. But not much later, even in 2009, they have taken a photo like this. Really, it's not necessary. In mucinous adenoma, you can perfectly do a laparoscopy and give a good wash. You do not have to do a laparotomy. Even if a little bit of mucinous content goes into the abdomen, a good wash will take care of it, and you do not have to show off trophies like this and publish them. See, this is a case in a 62-year-old lady with undiagnosed, because CA125 was normal, only 2 in this lady. And so I'm puncturing the cyst. It's much above the umbilicus. And then I put in the laparoscope and found it was an inoperable ovarian cancer. I took the biopsy, sent it off, and it was real florid cancer. So unless you want to take a biopsy, you have to open the abdomen, and then it becomes an unnecessary laparotomy. And CA125 was wrong in this case. After surgery, I again did the CA125, it was again 2. So the point is, intraoperative rupture of benign mucinous cystadenoma does not increase its recurrence, and laparoscopic removal of benign mucinous cyst is safe. Just worrying about something might be malignant is not really the reason why you should be operating on all mucinous cystadenoma. Because, you know, as we grow, our brain increases, and so also our laparoscopic skill is increasing. And even in advanced cases, good laparoscopic surgeons can do a good surgery. After all this laparoscopy started with an ovarian cyst enucleation in 1971. Therapeutic laparoscopy was started in 1970s. An appendicectomy was done in 1981. And since then, you have to be creating clarity from chaos. Ye karo, wo karo, wo karo, nahi karo, because everybody is just in evolving stage. But today we do have a clarity on everything. Why they say cancer is spreading after laparoscopy? The possible reasons that they are saying is that the spilled tumor cells drift to the trocar site by contaminated instruments and pneumoperitoneum. And the presence of ascites and direct contact of the tumor to the trocar site can cause metastasis. Ischemia of the port sites will lead to higher implantation of tumor cells. CO2 and smoke from the electrocautery from the tumor sites, and it will implant there like a chimney effect, you know. It goes up in a forceful direction. That's why the tumor cells are going. Another thing is damage of the peritoneal mesothelium. So because of the carbon dioxide or whatever. So all this, they are saying that cancers can spread if you do a laparoscopy. And they can cause pressure, and why you should not be doing laparoscopy, the possible reasons they took out. But if you do exercise like this, man, you will never get anywhere. You have to work hard and find out how you can avoid all these allegations against laparoscopy. So, and then only you can start, you know, dancing like this bird. So what are the means that you can do it? One is that suture the peritoneum, excising the whole trocar site and suturing layer by layer. So these are some of the things that you can do. Somewhere I did something and my slides are not moving. Okay. edit something and I'll have to go and come back again. Sorry. Where is the share screen button now? Okay.
Shobana, you close and start from the beginning.
I think you have, yeah, it's showing your other
Start
screen.
from the beginning. First slide.
My PPT is just not moving now.
That's what. Close
I was trying to read it and then everything went off. We'll have to. Okay, now it's moving. Can you see me now?
No,
Yes,
only
You have to share again.
Share.
You have,
but at least
I
my
could see
PPT
you
started
every
moving
time,
now.
but your slides
my-
are not there.
You have to share again. You have
I
to stop
shared again,
sharing
but
and
my
then.
PPT started moving at least now. Okay.
Yeah,
Me now?
like this. Now
Now
you
we can
start.
Can you see my PPT now?
Yes, ma'am.
Yeah, you can see.
Yeah. You give abundant peritoneal wash. Frequent removal of instruments can increase the chance for tumor infiltration. So try to don't remove your instruments as much as possible. And then you can start dancing like that bird. This use of gasless laparoscopy was there earlier, but somehow it is not picked up very much. And so just like gasless, avoid sudden deflation of the peritoneum to avoid the chimney effect. That is one thing that you can do. Use endobags to retrieve all suspected ovarian tumors. I also do that for endometriomas now because you never know which of them have got cancer. When you go abroad and all, you find a lot of people, whenever you do ovarian tumors, whether benign, malignant, whatever it is, make it a practice to put it in endobags all the time. And remove the endobag without morcellation to a mini lap or colpotomy wound or through the culdotomy wound, so that it doesn't get spilled. And what about ovarian masses without definite diagnosis, no facility for fresh frozen biopsy? See, this is a patient with 8 centimeter ovarian cyst with solid components, but normal CA125. There was loss of weight for 6 months and she was only 40 years of age. And this was actually a lot of additions in the abdomen was there, but there is no tissue biopsy. And there was so much of addition and the bladder was totally stuck up in front. And I did an LAVH and BSO. It was a this thing. Coming from the stomach, what do you call it? Suddenly I forget. The tumor cells from the stomach falling.
Krukenberg.
Word suddenly went off. See, that's the uterus stuck to the anterior abdominal wall, and with great difficulty I took it out. It was a Krukenberg tumor, and the primary they could not find in spite of doing a gastroscopy but in such cases also laparoscopy is allowed, So it's a tumor originating outside the ovary where the cells spill on the ovary forming a tumor. And in such cases, you have to do a gastroscopy. Once the husband came and fought with me. You knew it was a tumor, inoperable, and you unnecessarily operated on me because when they tried to do an endoscopy for the patient, they could not put in the gastroscope. There was so much of tumor inside the stomach. And the husband was blaming me for not finding that out. When we tried to do a barium meal, they could not swallow the barium meal because there was no space in the stomach. And to that extent, we people don't realize, we think we only look at the ovary. So Krukenbergs can be a fallacious thing. And suppose somebody from outside the space, they see all the gymnasts and they think that everybody can do it because human beings are all like this. It's like that. Not everybody can do laparoscopy. And everybody is not, us are not gymnasts. But depending on your capability, then only you should do a laparoscopy. So if there is a total solid tumor like this, even if you know laparoscopy, you are not supposed to do it. This was a germ cell tumor in a very young 9th standard girl. And she's hale and hearty 2-3 years after surgery. But these are cases where you are not allowed to do a laparoscopy, whether endobag or no bag, because they're huge tumors, just 15 centimeter big. So there are certain lines that you have to leave. But it is safe in masses less than 5 centimeter. And various people from various journals have said that. I have taken 2 or 3 only to be put here. And suppose a postmenopausal woman with a 6 centimeter cyst with solid areas comes with normal color Doppler. I did do a LAVH with BSO. It was a transitional cell tumor. And CT scan 1 week later showed recurrence with 7 centimeter nodes, which is nonsense because post chemotherapy, the patient is hale and hearty, probably 10 years later. Now, another patient, let me tell you, this 80-year-old lady had ascites and was diagnosed as ascites cancer. But aspiration cytology did not yield cells, and she had severe left ventricular dysfunction. Only 40% ejection fraction was there. They just wanted tissue biopsy. And I did a laparoscopy. I said, I'll go in and quick, and I'll come out quick, and the anesthetist agreed to me. And then in spite of taking a tissue from all those excrescences that could be seen, they still said, we cannot type it. Can you imagine that? Given tissue, they can't type it. So for that, if you do a laparotomy, that's very unfair. Aspiration cytology is not yielding tissue. So such cases, there definitely laparoscopy has got a role, whatever it is. And even if the ejection fraction is low, you should not open a woman like this because that just gives so much of pain and inability, disability. So laparoscopy does have a place in cases like this. So another case is a 22-year-old unmarried girl who had come to me with this picture, And again, the CA125 is raised, so we all think it is cancer. But and there was minimal ascites, but it was only tuberculosis. And unfortunately, I thought it was cancer, but then they got angry with me. They ran off. But later on, I realized that nobody believed that I had written what I wrote, and they opened her again. She had to go through a lot of tough times, and it was just tuberculosis. And because in Kerala, we don't see much, and we are not used to seeing such fulminant cases of tuberculosis. So such the places, laparoscopy does have a role. Again, another 65-year-old lady with a history of stroke, and she's on anticoagulants, And then when you do surgery, you will prick everywhere. She's a 13 centimeter ovarian cyst, multiseptate, with normal CA125, no ascites, no lymph nodes. Posted for laparoscopy, but you could not even give bowel preparation as the patient had diarrhea. Then what is the point in giving bowel preparation? She was on disposable diapers, that much she had diarrhea. And this was a plain simple cyst. Can you imagine? You get so scared of such patients and just plain simple cyst. And sometimes they are even para-ovarian cysts. So there is definitely a role for laparoscopy because you cause very less bleeding when you're using a cautery of a 10 millimeter cautery or single and putting it or a 5 millimeter cautery. So getting scared of laparoscopy is not the done thing. Especially when patients are on anticoagulants, I feel that small bleeding that is caused by the suturing, putting the needle here, putting the needle there, that can cause more bleeding than the cautery of a laparoscopy. Especially I have a 10 millimeter one with me, so it really doesn't bleed. And at least you can watch for a long time on the laparoscope. So patients on anticoagulants, I feel our anesthetists should be a little more lenient with us. Sometimes anesthetists don't agree, There are such risky cases, you go open the case. So I think all over the country, people, whether you're good or bad, I think the anesthetist should be cajoled into giving anesthesia for people who are even on anticoagulants, even if they have stroke, even if they are poor candidates, because the cautery and the way vision is much better on a laparoscopy compared to a laparotomy. So from cancer and borderline cancer, let's go on to post-hysterectomy patients. When they come with excruciating pain, we always think of twisted ovaries. But in this patient was not having a twisted ovary. It's not moving. Oh God. Can you see this video is not moving? I have not pasted it properly. You can see yellow tissue all around and just a little bit of white tissue in between. But when I was searching where to put the trocar, because all the yellow tissue you think is bowel, you cannot go into that. And that white tissue I opened and I found that there is no ovarian cyst. All that was just addition of the bowel with collection of fluid inside. So it was actually a properitoneal cyst. That is, the diagnosis should be made on transvaginal grayscale image. You should show a spider web pattern with the presence of loculated fluid, and you can see an eccentric ovary on the left side. So that is how you may be able to diagnose it before, but once you have diagnosed it, but when the patient comes with excruciating pain, you have to do a surgery and be aware. But this is another patient where I did land into a problem. This is a patient with a excruciating pain. She had come with 3 centimeter ovarian cyst, and on putting the laparoscope, this is midline additions are there. And this, let me tell you, this is only, the scope is actually lying in the right compartment of the abdomen. I thought I was in the whole of the abdomen, but no, I was wrong. This was only the right compartment of the ovary, of the abdomen. And when I pulled the scope out, I could actually put it into the other compartment on the left side, now that you're going to see. So the midline additions with the bowel were so thick that you think the pain the patient had got was because of the ovarian cyst. Unfortunately, the pain in this patient was caused because of the very, very dense additions of the bowel to the anterior abdominal wall. And she did get a bowel injury, and the gastrosurgeon had to be called, and the cyst was innocuous, but the way they had pain, it was a mistake on my part to think that all pain is because of ovarian cyst. I recently also had a patient whom I had operated some 8 years back. She had a hysterectomy, and she insisted that you please open me and do it, because everybody says laparoscopy is bad, and I had to open her. But unfortunately, she had a bleeding from one of the edges, and I had to reopen her. And then I had closed her. Then every time she would have a small 3 centimeter ovarian cyst, and all doctors would say nothing can be done, leave it alone, leave it alone. And after, in the end of 6 years, she keeps getting pain, and she comes to me and she says, oh, now the cyst is 4 centimeters. Then I said, okay, let me I'll do a laparoscopy for you now. And when I did it, again, the same thing. There were just bowel additions to the anterior abdominal wall because of the repeat surgery that I myself had done. And once I released the bowel additions, I could not really find any ovarian cyst anywhere. Let me tell you that. I'm telling you my own mistakes, but quite often I have seen that intestinal additions can cause severe pain, which will mimic the pain of the ovarian cyst. And when you put your scope inside, you will not find any ovarian cyst. But then the patient is relieved of the pain, but then you have to be careful, because bowel can get injured very fast. And another thing is, whenever you release bowel additions, they can come back again after a few years. And then I have actually released additions twice in one patient, 5 times in another patient. And everybody criticizes me when I show that series of videos where I've done bowel addition release for 5 times between 1996 and 2016. 5 times I've done adhesiolysis. But yes, additions can cause pain, and they come as ovarian cyst or something which induces you to do a laparoscopy. But quite often it is because of the additions, not the ovarian cyst. So that you have to keep in mind. So this is another point, that even in old age, I have twice or thrice encountered this. It's not that when you get old, you won't get it. You can get twisted ovarian cyst even in old age. And then when it comes to you, you don't realize that the best part is, when it comes in old age, you do not have to do a cystectomy. You can just knock off the ovary. That's the best part in young girls. But when it is gangrenous and you do a laparoscopy, if the ovary just dies off, they will blame you. They won't blame the gangrene, they will blame you. That's what happens. But in old age, you do not have to worry about it. You can just remove the knock off the ovary, and that's it. So today I will do what others won't, so that tomorrow I can do what others can't do. So you have to advance in laparoscopy, then only you can do the best that everybody does. thank you for listening to me and giving me this topic. She asked me about a topic and I can't prepare one every week, no? So I take one topic from my attic. This I had presented in Bhubaneswar, lying in my attic for a long time. And thank you, Asna, for letting me present this.
Thank you so much, ma'am.
Yeah, Asna, Dr. Anju
Good,
Soni here.
good evening, ma'am. Good evening.
Yeah,
Welcome.
I'm sorry
Welcome,
I
Anju.
couldn't. Yeah, sorry I couldn't join earlier because at Jaipur we are all busy preparing for the conference.
Yes,
So,
ma'am. We can understand.
You can chair the second session. We have just changed
so yeah,
because
okay.
you were not there. So we have changed a little
Yeah.
bit. So you can
Okay.
chair the second session of the Asna. So she will be happy.
Congratulations,
And-
Dr. Yashodhara, for organizing this beautiful program. I think
Thank
ovary
you,
is one of the
Anju.
most difficult organ to understand,
I
starting
know,
from
I know.
adolescence to menopause. So taking up
Shobna
this
has put me in
organ.
the soup. Shobna has put me in the soup.
Me?
Yeah.
Now Anju is saying that she is busy with the Jaipur conference. I also can't prepare because of her Jaipur conference. Because she has given me stem cells and I'm wondering.
Shobna, your talk was wonderful. It was really good. I'm sure the chairperson is going to conclude it, but I just wanted to say that's a wonderful, because to accept and say what has happened is need a real this thing. The goody everybody can show.
They always say I show the
So is
complications.
Seema there? Is Seema
Okay,
there
Reena.
to conclude?
Reena, ma'am.
Nice. Thank you, Shobna. And you have given so many tricks, and how so many people are saying that actually ovary is a big notorious organ. Without any signs of M signs, it can be malignant. Without any B signs, it could. Without any B signs, it could be malignant. So all that is always there, and only it is the final diagnosis when we see it. Maybe laparoscopy, maybe laparotomy. But laparoscopy, for a message for everybody, one who is very well versed with laparoscopy, only then they should attempt to it, one thing. And doing a simple biopsy and taking out the fluid. Do you think it is all right when you are you're not confirmed about it's being malignant?
I think it's better than laparotomy for that reason. If you're sending it to an oncology center, you have to send it to an oncology center where they have frozen section and they will do at one go everything. That's okay. But just to take a biopsy out, doing a laparotomy like in olden times is not acceptable. There are guidelines on which ones you should do a laparoscopy, in a place where there is no oncology, and which where you should be doing surgery in an oncology center.
And there
that
is always
slide
a question
is missing from my PPT. I don't know, it got deleted. I had actually put a CD on
because
that.
Because it is not always that any tumor, ovarian tumor could be attempted with a laparoscope. Definitely,
no,
you
but
have told
with good surgeons, it can be attempted. Sir, madam, the point is when you're doing a laparoscopy for an ovarian tumor, what is going to happen is you are supposed to give out less than 3 centimeter of the pelvic wall, 3 centimeter gap between your Macan rod and the pelvic wall. That is how much clearance you're supposed to give. If you can give that clearance on laparoscopy, that is okay. But if it is so vascular that if it's going to bleed, even in open surgery, if you go on taking sutures, it's going to bleed. And your sutures won't catch, your cautery won't catch, and it will go on bleeding. The minute you touch it, it will go on bleeding. That is called inoperable. And that inoperable, whether it is laparoscopy or laparotomy, you have to take a biopsy and go. That's it.
Yeah, that's
it's not bleeding that much. Then a good laparoscopic surgeon can do it. If it is if it is
that
operable,
is what I wanted to say. That even the spillage is not allowed. Suppose it comes out to be malignant on biopsy later on, the spillage is also not allowed. What these oncology people say, that only, and one should have an oncosurgeon in hand whenever you are going to operate upon ovarians.
There are guidelines for that.
It can be turned out to be
put that slide
so,
on. Sorry.
Yeah, that message should be with everyone. And your slides were so nice, and your cases were so nice to learn for everybody. Thank you for your nice deliberation.
I hope you'll bring that out in your panel. I'm sorry that slide got deleted.
That panel people will bring out.
Yeah, big applause.
Thank you so much.
It was a very good presentation.
Yes, ma'am.
Very good presentation. Did you use anti-adhesives, adhesive agents? Because repeatedly
Madam,
for
only
one
once
case
I
you
have
did
used
5
Interseed.
times.
Only once I have used Interseed. In that I told you one patient I have done 5 times additions. Now
Yeah,
once
that's
I have
what.
used Interseed, because when Interseed is there, if Interseed has to be put, there should be absolutely no bleeding. Okay, twice I have used Interseed, let me tell you. Once in that Bushra case where I have done 5 times adhesiolysis. But that Interseed really didn't make sense because after 2 years again, she came back with addition. Another time I used Interseed was in a patient where I did 5 myomectomies, 5 fibroids are removed through the laparoscope. And I put an Interseed. At that time, I didn't know about the Interseed. This patient came back with severe pain. Let me tell you, after some 15 days, like whenever she has food and all, she gets pain. And what happened is when I went and saw the video again, I saw that I had left behind one fibroid. I thought that whatever pain she had was because of, she is just natak karti hai wo, isliye bolti hai aisa. But then, just for removing this one fibroid, I said, I'll do it little less cost, only you give hospital cost, I won't take any money, but please come back. Because I did leave one fibroid behind. And I went back to remove that one chota sa fibroid, because at that time I was young, I was feeling very guilty. Ek chota sa fibroid se kya hone wale, kuch nahi. But when I put the thing back in, let me tell you, the fundus of the uterus was stuck to the abdominal wall. And then I put Interseed, and why this happened. And when I went and read the literature on Interseed, if you put Interseed on a bleeding place, it will cause more addition. For God's sake. And that literature is not openly available. I found it in one small book somewhere. I read. Because in my textbook of complications, also my chapter is on post-op additions. I've got 44 chapter in it with various people from India, but my chapter was on post-op addition. And udhar bhi maine pada nahi tha. But yes, Interseed has to be put in when there is no bleeding. And in that patient, because she was bleeding, oozing from the fibroid, I put in Interseed and it was stuck to the anterior abdominal wall, and girl's pain was really proper. She was crying of pain. That was correct. So Interseed is good, bad, I don't know, but it has to be put when there is no bleeding. And in a patient with multiple additions, to get a bloodless field on laparoscopy or laparotomy, it's a tough call to make. Let me tell you that.
Thank you,
Very nice
Dr.
discussion.
Shobna.
Can we
Very
start
nice
with the
discussion. And thank you. And I don't think more questions are there, so we can proceed on to the next. Dr.
Yes.
Asna.
Thank you, Reena ji.
Thank you, Reena ma'am. And thank you, Uma ma'am, too. Now we move on to the another session. And this is a session we have a speaker as Dr. Asna. And I invite Anju Soni ma'am to introduce Dr. Asna.
Yeah.
Do we have Uma ma'am?
Can I see the slides?
Yeah. Do we have Uma ma'am also? Dr. Uma? No, we don't have her. Yes. So, Dr. Anju, you can go ahead, please.
Yeah.
Even
So,
Seema was expected in the last. Is she there? She can join.
Yeah. So,
Yes,
first of
Seema
all,
has not spoken
congratulations.
anything. She was called in as a chairperson. Where is Seema?
I'm here, madam.
Okay,
Yeah.
you please,
Dr.
yeah.
Seema, you also can join us, chairperson.
She was there from before. She's a chairperson for my session. She has not given her remarks.
So now she can come for this. She can come for this session and she can give the remark in the Dr. Asna session. I'm sure.
Yeah.
Seema, are you comfortable?
Yeah. But Dr. Shobna is as always, she is the star speaker of Indian Menopause Society, and it's really a great initiative to have these webinars here. And regarding your next session, Dr. Asna is also going to have a very interesting talk about.
Can I introduce Seema? Can I introduce Dr. Asna, please?
Yeah.
So it's my pleasure to first introduce Dr. Asna Asraf. She's a consultant OBGYN and an endoscopic surgeon in Ujala Medical College and secretary of Lucknow Menopause Society. And what more I want to tell about her is that she is one of very active members of Indian Menopause Society, who has done a lot of academic work, got medals and best paper award for at UPCOG. So
Thank
welcome,
you.
Dr. Asna. I know the
Thank you,
topic you are
ma'am.
going
Thank
to
you so
talk.
much.
Your topic you are going to talk about is another complex topics which which there are a lot of problems in this topic and lot of people don't know about it. And when a patient comes to us with chronic pelvic pain after her ovaries are removed, there is what we we are in the soup. So welcome and address this topic.
Thank you so much, Anju ma'am. Thank you so much, and a very good evening to everyone. My topic today is residual ovary syndrome, but I will also be briefly touching upon ovarian remnant syndrome and a little bit about clinical decision making. So hysterectomy is the most common major surgical procedure performed in perimenopausal women and is often presumed to be an endpoint of all gynecological problems by the woman and her family. But pelvic masses after hysterectomy can arise from conserved ovaries, ovarian remnants, retained fallopian tubes, broad ligament, and other pelvic viscera. The emergence of a pelvic mass has a profound physical and psychological impact on the patient and poses a diagnostic and therapeutic challenge to the gynecologist. So, I would like to begin today's discussion by presenting a case. This was a patient that recently came to me. She's a 50-year-old para 4 with severe pain left lower abdomen following intercourse the previous night. And she had a history of previous 3 cesareans, and a total abdominal hysterectomy with bilateral salpingectomy was done 2 years back at a different hospital. And this was done for abnormal uterine bleeding. She had a history of heavy menstrual bleeding, not responding to medical management for 10 years before the surgery. And in the surgical notes, it was written that both her ovaries were normal and had been conserved. So when she came to me, I examined her, and there was tenderness in the left iliac fossa and the suprapubic region, and there was a vaginal discharge as well. And I did the per vaginum examination, and there was tenderness in the vault region, and it was more on the left side. So her transvaginal sonography showed a well-defined complex cystic lesion with internal echos and septations on the left side, and it was posterior to the urinary bladder. The size was approximately 45 by 43 by 30 millimeters, and the volume approximately 30 cc, and it had mild peripheral vascularity. So I started NSAIDs and anti-inflammatory medication and sent the routine investigations and CA-125, and they came back to be normal. So a diagnosis of residual ovary syndrome was made after reviewing her previous surgical record and investigations. And the treatment plan, I decided to keep her under observation. Surgical option was discussed, but she wanted to avoid surgery at any cost. So considering her pain and tenderness, I also started her on doxycycline and metrogyl for PID. And I called her after 2 weeks. When she came back after 16 days, her lower abdominal pain had subsided, and the repeat TVS showed that the left ovarian complex cyst had reduced considerably in size. It was now 20 by 18 by 15 millimeters, and the volume had also reduced. So I sent her back on just calcium and vitamin D and called her after 3 months to do to get a repeat TVS done. So she came back last week, and her ovary was now normal in appearance, and it also showed a small follicle 8 by 7 millimeters. So what is residual ovary syndrome? It is a complication after hysterectomy in which one or both ovaries that had been intentionally conserved either develop an abnormal pathological process or cause symptoms requiring surgical removal. The incidence is estimated to be 1 to 4%. The cluster of symptoms include chronic pelvic pain, asymptomatic pelvic mass, and dyspareunia. In a retrospective analysis of more than 2,500 hysterectomies for benign diseases by Deckel et al., over a period of 20 years, the incidence was found to be 2.85%. That is, 1 in 35 women who underwent hysterectomy with ovarian preservation became symptomatic. They experienced pelvic pain, often with the presence of a benign cyst. Almost 50% of these patients required surgery within the first 5 years after hysterectomy, and 75% within 10 years. So the possible pathologies that can occur in residual ovaries include follicular cysts, hemorrhagic corpus luteum, endometriomas, peri-ovarian adhesions, benign and malignant ovarian neoplasms. Most of the published case series describe ovarian malignant change in no more than the general population as a whole, which is about 1 to 2%. So coming to the management, a review of the operation notes of the previous surgery is of immense help regarding indications of surgery, whether one or both ovaries were removed or conserved, and the state of the pelvic structures at the time of the surgery. Proper documentation on the part of the surgeon is very important, and so is the careful preservation of the discharge notes and histopathology reports by the patient, and that should be a part of the post-operative counseling that we do. So conservative management, functional cysts or hemorrhage in the cysts may resolve on their own, and the patient can be kept under observation after counseling if all the investigations are normal, and then later on the scans can be repeated. Coming to the surgical management, chronic pelvic pain was the main indication for surgery in 71% of cases in the Deckel et al. Series, and asymptomatic pelvic mass accounted for 25% of repeat surgeries. So a meticulous bowel preparation, careful dissection, these are very important because adhesions are very common in such cases. Laparoscopy has reduced surgical morbidity. However, adhesions may make a laparoscopic approach more difficult. And for laparoscopy, as we all know, the proper equipment and the proper skill has to be in place. So moving on to the other entity, which is ovarian remnant syndrome, it is actually not very well understood, and it is not that common also, and it is often confused with residual ovary syndrome, and some people think that it's a synonym, which it is definitely not. So ovarian remnant syndrome is defined as the persistence of functional ovarian tissue after bilateral oophorectomy with or without hysterectomy. It usually results from unintentional, incomplete dissection and removal of the ovary during a difficult oophorectomy. The incidence is not exactly known because there are only case studies, there are no randomized controlled trials or anything like that. And it usually presents as persistent cyclic or chronic pelvic pain with or without findings of a pelvic mass. And the pain is often dismissed as not gynecological in origin. Unfortunately, awareness of the problem is not widespread, and often these patients have been to many gynecologists, even general surgeons, and sometimes even to psychiatrists in an attempt to get relief for their symptoms. The risk factors are usually a history of extensive endometriosis, pelvic inflammatory disease, multiple previous surgeries, inflammatory bowel disease, and neoplastic lesions. So the three major factors that may complicate the initial surgery and make it difficult for the surgeon to ascertain whether all ovarian tissue has been removed are an increased pelvic vascularity, which usually makes hemostasis difficult, pelvic adhesions, which distort the anatomy and make dissection difficult, and neoplasms, which also distort the anatomy. So even if the infundibulopelvic ligament is adequately ligated during TLH-BSO, an ovarian remnant can still be left behind. And the other mechanism by which this can happen is the implantation and growth of displaced ovarian remnants in the pelvic cavity. They can grow on the pelvic side wall, over the peritoneum, over the bowel. They can grow anywhere. And this can happen due to neovascularization in the ovarian remnants. So the diagnosis is quite difficult. It is based on a history of BSO, the symptoms, pelvic examination, and imaging with ultrasound. CT and MRI may help in some cases, and the diagnosis may be enhanced by measuring serum levels of FSH and estradiol, and they would be in the premenopausal range because the ovaries are functioning, and what is expected after oophorectomy is that the patient will have menopausal symptoms and hormones in the menopausal range. And some people have also tried giving a course of ovulation induction with clomiphene citrate to increase the size of the cysts. And sometimes it happens that after clomiphene citrates, ovarian remnant, which was not visible earlier because of the formation of multiple cysts, multiple follicles which start growing because of the clomiphene citrate, it becomes visible on an ultrasound. So the definitive criteria for diagnosis is only histological documentation of ovarian tissue obtained by surgical excision. So the treatment of choice is surgery. Patients with a pelvic mass require appropriate evaluation for malignancy, typically surgical exploration and excision. And laparoscopy is the preferred treatment. Pharmacological therapy is a reasonable option for symptomatic patients with suspected ORS who have no pelvic mass and who are not candidates for surgery, or patients who refuse surgery. Patients should be counseled about the limited data on efficacy, lack of a histological diagnosis, and the risk of ovarian cancer in the remnant ovarian tissue. Various people have tried different modalities, oral contraceptive pills, GnRH agonists, and high-dose progestogens have also been tried, but there are no standardized treatments for this. So ovary is an endocrine organ with widespread physiological effects during the postmenopausal as well as the reproductive years. And you will all agree with me that this is a beautiful picture of a section of a human ovary under the light microscope with a beautiful follicle in the center. Bilateral oophorectomy results in an abrupt drop in estrogen, an abrupt rise in the follicle stimulating hormone, and the complete cessation of ovarian hormone production, including androgens, estradiol, and progesterone. So, elective oophorectomy or ovarian conservation at the time of hysterectomy. There are no easy answers for this question. Clinical decision making about oophorectomy, and this is in the context of healthy ovaries. We are talking about healthy ovaries here. So elective salpingo-oophorectomy is removal of the ovaries and tubes in a patient who has no known indication for this procedure. We call it risk-reducing salpingo-oophorectomy when removal of the ovaries and tubes is done in a patient who is at high risk of ovarian or breast cancer due to a known gene mutation like BRCA1 and BRCA2. And risk reduction involves the removal of both the tubes and both ovaries, because many ovarian cancers have their origin in the tubal epithelium. And then risk-reducing salpingectomy is removal of just the fallopian tubes in a patient with a general population risk of ovarian cancer. So the decision regarding oophorectomy at the time of hysterectomy for benign disease should include an assessment for risk factors for ovarian and breast cancer, evaluation for extrauterine pelvic pathology like adhesions, comprehensive preoperative counseling regarding the risks and benefits, and a shared decision-making between the gynecologist and the patient. Bilateral salpingo-oophorectomy is an important risk reduction strategy for patients who are at high risk of ovarian cancer. The lifetime risk of ovarian cancer in the general population is 1.4%, compared to 13 to 46% in patients with BRCA1, BRCA2 gene mutations, and up to 38% in those with Lynch syndrome. So BSO in these patients is considered risk-reducing and not elective. BSO reduces the risk of ovarian cancer by up to 80 to 90% and breast cancer by 50 to 60%. However, majority of the women in the general population are at an average risk of ovarian and breast cancer, and the risks associated with bilateral oophorectomy before the age of 50 years far outweigh the benefits. Ovarian conservation at the time of hysterectomy and long-term health outcomes in the Nurses' Health Study. This was a landmark study published in the Green Journal in 2009. It was a prospective study of 29,000 women followed over 24 years. And the women were divided into two groups, one with hysterectomy and bilateral oophorectomy and the other with ovarian conservation. And they concluded that bilateral oophorectomy before age 50 years was associated with an increased risk of all-cause mortality, coronary heart disease, stroke, and lung cancer, amounting to 1 additional death for every 9 oophorectomies performed. So the risks of elective oophorectomy include increased risk of cardiovascular disease by 33%, osteoporosis and hip fractures by 50%, cognitive impairment, dementia and Parkinsonism, colorectal and lung cancers, chronic kidney disease, impaired sexual function, and an increased risk of all-cause mortality by 28%. And it has been seen that these risks are highest if the oophorectomy is performed in women who are younger than 45 years of age. So, ovarian conservation ovarian conservation until at least age 65 benefits long-term survival for women at average risk of ovarian cancer when undergoing hysterectomy for benign disease. The Indian Menopause Society's guidance says that a significant number of hysterectomies along with bilateral oophorectomies are performed at a young age. This trend of unwarranted hysterectomies and surgical castration for fear of cancer by the professional and the women should be discouraged. So now a quick recap of the differences between residual ovary syndrome and ovarian remnant syndrome. Residual ovary syndrome in residual ovary syndrome, the previous surgery is hysterectomy with ovarian preservation, whereas in ovarian remnant syndrome, it is oophorectomy with or without hysterectomy. In ROS, the intentionally conserved healthy ovaries later on develop some pathology, whereas in ovarian remnant syndrome, small piece of ovarian tissue unintentionally left behind grows and produces symptoms. The incidence is 1 to 4% in residual ovary syndrome, whereas in ovarian remnant syndrome, the incidence is not exactly known. On an ultrasound, we will see a cystic or a solid pelvic mass in cases of residual ovary syndrome, whereas in ovarian remnant syndrome, the pelvic mass may or may not be seen. And the management can be conservative in some cases of residual ovary syndrome, and it can also be surgical if conservative management fails or if the size of the cyst does not decrease. Whereas in ovarian remnant syndrome, the management is only surgical because because there is a risk of endometriosis and ovarian malignancy in the remnant ovarian tissues. So to conclude, all post-hysterectomy and post-BSO patients complaining of chronic pelvic pain should be carefully evaluated to rule out residual ovary syndrome and ovarian remnant syndrome as the case may be. The decision regarding oophorectomy with hysterectomy for benign indications must include comprehensive counseling regarding the risks and benefits and a shared decision-making between the gynecologist and the patient. The hypothetical need for subsequent surgery does not justify the deleterious long-term consequences of elective oophorectomy for most patients, especially younger than 50 years, undergoing hysterectomy. Thank you so much for a patient listening.
Thank you so much, Dr. Asna. It was a very comprehensive talk and very clear, crisp messages, of course. I would like to call upon Dr. Seema or Dr. Uma, who can put up the closing remarks, please.
Yeah, Dr. Asna very beautifully summarized the things about premature surgical castration, which should really be discouraged from our side. And Indian Menopause Society is also discouraging it. It is given in guidelines also. It is our consensus. So it was a really very nice talk elaborating on the points regarding resistant ovary. So thank you very much, and I congratulate Yashodhara Madam and all the Lucknow Menopause Society for having this great discussion today.
Thank you, Seema.
Thank you so much.
And it's a very comprehensive talk, but only thing I just want to make a comment, Asna, that you have shown that it is 50 to 75% women needed a surgery. But in my experience of more than 30 years, I have seen the surveillance have reduced, avoided a surgery in many, many women. It is a counseling and the surveillance. And I hardly have a 10%. I must have seen these patients more than 200, 300 patients. I don't have the record, but hardly I have done 3 or 4 or 5 women who have needed a repeat surgery. Otherwise, everybody has been resolved after some time because either they achieve menopause or something like that. So they all achieve this thing.
I will
And
also take one
I did
minute
not
to
record.
give one case. I had
Thank
two
you.
cases of ovarian remnant syndrome. One patient had undergone an oophorectomy by another doctor. Then she came to me for hysterectomy, and after VH, I found there is another cyst in the other ovary. So hysterectomy with the remaining ovary was removed, and every time she would come with pain, 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 pain. She had initially come to me with pain at the site of the previous oophorectomy. In spite of removing the ovary, other ovary and the uterus, still she had the same pain. And then she was put on OC pills, and for some 10 years she took OC pills and she was relieved. But the minute she stops OC pills, she again gets the pain. And after the age of menopause, she had no problem. Similarly, another patient, very fat patient, who had undergone 2 or 3 surgeries, and again this pain after removing ovaries. But with OC pills, it subsided. So these are my experiences, and even Dr. Yashodhara is reiterating that surgery, you search, because she told me that right ovary was removed and that is where she gets the pain. When I put the laparoscope in to remove her uterus and the other ovary, I could not find anything what to remove. Remnant kahan se dikhega? So you have to put them on OC pills or something else.
Thank you, Shobna, for supporting my evidence also. But we have to jot it down everything to make it a real Indian experience and this thing. Otherwise, we are at loss.
Ma'am, can I reply to your query?
Asna,
Yes,
we will
Asna.
discuss later on because we are already
Ma'am,
short of time.
since you have
reply,
there is some disturbance.
no, reply fast, Asna.
So, ma'am, actually, this is the data that I have presented. It is from the study by Deckel et al. And it was published in the European Journal of Obs and Gynae. They did a 20-year follow-up, and this is what they found.
Asna et al. Will give a study after 10 years.
Yes. Hopefully, ma'am.
Thank you.
I
saw that Deckel and et al. Study. I saw that.
So it is from that.
I will come with true report.
Yeah, but we are losing time on the very big panel.
Yeah.
It's 6
Yes.
cases and all those.
Go ahead,
things.
go ahead.
Thank you, everyone. Now is the time for a very good session, and that is the panel discussion. And I invite Yashodhara Pradeep ma'am. She is our president and also vice president elect Foxy for 22-23. She has lots of laurels to her
Amrit, that's enough.
I think we all know her, so I wouldn't go into detail. And similarly, I have Dr. Naini also as one of the moderator. She also is a very enthusiastic IMS, LMS candidate who is really very hardworking and a very intelligent and very
Thank you, Dr. Amrit.
So I invite both of you to introduce the panelists and also carry on your panel.
Thank you, Dr. Amrit. Now I welcome our very dynamic and learned panelists. First is Dr. Anju Rani. She's a senior consultant with SGPGI, Lucknow. Kindly please change the slide. Then Dr. Indulata Sahu. She is also a professor in the Department of Maternal and Reproductive Health, SGPGI, Lucknow. Our third panelist is Dr. Sangeeta Mehrotra. She is a private practitioner and she is the Joint Secretary of LMS. Our fourth panelist is Dr. Shipra Kumar. She is a consultant, Manipal Hospital, Pune, and she has just shifted to Pune from Lucknow. Dr. Shuchi Agarwal. She is Associate Professor, Department of Obs and Gynae, KGMU. And in the end, Dr. Vaishali Jain. She is Head and Faculty for DNB, Department of Obs and Gynae, Vivekanand Polyclinic and Institute of Medical Sciences, Lucknow. I welcome all of you. Dr. Yashodhara, you please start the panel discussion.
Yes. So, Asna, will you share this thing?
Already shared, ma'am.
Already shared. Yes, thank you. So, good morning, good evening to everyone. And I'm really thankful that everybody has joined. And as I said, that everybody has said that this topic, ovarian, is a really difficult topic because it has got so many windows to open once you go into the ovarian. And it's very difficult to say that it is a benign or is a malignant. And we all know that ovarian malignancy is having a high, very bad prognosis, very high mortality. So we have to have something which can make an early diagnosis of the difference between benign or malignant. Because we have also, previous two speakers have emphasized the complications of surgery. And I don't have time, so I cannot share my own views on this thing. I'll just go into the panel. If the time, discussion time is left, then only I will share that. So Asna, please go back, or I can go back from my side. No, I cannot go back from my side probably. Yeah. So with this, thank you, Nani, for co-moderating with me and for introducing my esteemed panelist. I cannot go back now. Asna, from my side, that's the difference actually when you don't do it yourself. You are rely only on this thing. So as I have said that, we have said that ovarian masses, and with every modality has got some good and some bad. More good, but a little bit of bad also. So our part, gynecologists have, because since the ultrasound has come, we started seeing so many ovarian cysts. So the responsibility of the gynecologist increases to interpret the report and see that whether it needs a expectant management, or it needs a surveillance, or it needs a surgery. So because this is how we are going to decide, and it is not only by doing this, we have to save ourselves from many complications also at times. So as it has been said, with the advent of this, we see in the premenopausal women, 8 to 35% of the women has been identified as having a ovarian cyst at some time of their life. And in the postmenopausal patients, there's a 3 to 17% chance. And there's a 10% lifetime chance for surgical intervention. Next. I'm not going, because few slides are there, but because of the time problem, scarcity, I'll just say the main point. Our objective of this panel is that to decide almost this ovarian cyst, ovarian mass. Cyst is not the thing. It should be, because there's so much in the terminology, whether to say cyst, whether to say tumor, whether to say adnexal mass. So it has been, I say ovarian mass at most of the times. So it is this ovarian mass which we have diagnosed mainly on by manual examination, or on the ultrasonography, or confirmed by the ultrasonography, I must say, almost every time we do ultrasonography. Whether it is almost certainly benign or reasonable chance of being malignant, so we can decide what route of management I am going to have. Next, please. Next, please. So this is a differential diagnosis we always keep in our mind. And this is a prevalence. We also keep this in mind, that what are the, this will come into the discussion, so I'm not elaborating it. Next, please. Next, please. Next, please. Next, please. So clinical presentation, we all are going to come up. This is how the patient presents. Gastrointestinal symptoms, which mostly people go to the physician or the general practitioner. They should also have the knowledge that whom to be referred and whom not to be referred. Because I have seen people have not written even the ultrasonology to these kind of a patient, and they have come with the big masses, and sometimes they're malignant also. Next, please. And this is how often these symptoms you get. Next, please. So they do not come directly to the gynecologist. They go to the either physician or the surgeon, or to the RMPs or the general practitioner. Yes, and this is a risk we are all going to discuss in the panel, so I'm not going to elaborate on it. Next, please. So as I have already said, that role of ultrasound is the first choice of investigation in the cases of any adnexal mass or the ovarian mass. Adnexal mass, because ovarian mass only we are going to say after the report. Before that, we always say it is an adnexal mass. So we can have grayscale Doppler, but combined grayscale and Doppler, R is missing. Grayscale and Doppler is the best method to evaluate these masses and to be differentiate between benign and malignant, or to say that it is almost certainly benign or it is a malignant. Spectrodoppler and 3D USG is not very used, but 3D USG is used mainly in the cases of hydrocycling. There you really, if you want to differentiate, the 3D is going to be very helpful. Next, please. Yes. So there is because of this problem and this complexity in the ovarian masses and the bad prognosis of the ovarian malignancy, there in 2008, there is an international ovarian tumor analysis was done. Then it was not having anything because it could not score. It just used to say what are the features are there and how to proceed with that. So in 2020, there is a American Society or Academy of Radiologists. They have come with the ovarian adnexal reporting and data system, that is ORADS, for risk stratification and management system for the sonologist. It is basically for the sonologist, but we know that all the time, because here we get differentiated whether you have to send it to a sonologist or you have to send it to the specialist sonologist. Because if you have not sent it to the specialist sonologist who is not aware of all this, may not be able to give you the good report. And so each and every obstetrician and gynecologist should know at least, or then they send it back the patient and can ask you a report on these points also. And that is how probably we are going to use this. Although this 2020 is not 2 years back only. So it looks very promising, but not widely used. So we cannot say how good it is going to be in the future. Next, please. So simple rules we are going to discuss. So I'm not going to discuss here. Next, please. This is also we are going to discuss in this thing. So I'm not going to discuss here. Next, please. So this is how we can, these next few slides, Asna, you can forward it, that it is what is the difference between the IOTA and ORDS. IOTA only talks about the features, but the ORADS or ORADS says about the stratification and the risk and the management also. So it is a good, because it's a scoring system. It makes things more visible, more comprehensive and more confident for a gynecologist in the management of the patient. So coming to the first question, and how do you define an ovarian cyst and prevalence of the benign ovarian masses? And Dr. Indu, will you be able to answer this question? How do you define an ovarian cyst and prevalence of the benign ovarian masses? Hello, Dr. Indu, are you there? Dr. Indu Lata, has she joined?
Yeah, she has joined.
Is she muted?
Dr. Indu, you need to unmute yourself, please.
Mr. Faraz, please unmute all the panelists.
Yes, ask host to unmute.
Okay. So first of all, good evening to everybody, my teachers, my colleague, and my juniors. And I especially thanks to IMS for giving me this opportunity and to answer this first question of the panel, that how will you define? So definition of the ovarian cyst is the collection of a fluid in the ovarian tissue inside the ovary, or it is on the surface of the ovary, and it should be at least more than 3 centimeters. Hello, am I audible?
Next, please, Asna.
Hello.
Always after the question, play the slide. If I can do it, I will be so happy to do it. Host, can you make it this that I can shift the slides?
Ma'am, I will do it. I've done it.
Yeah, you have done it, but it takes time. Yes. Next, please. Yes. Because the time is short, I cannot have. Wait. Yeah. Dr. Indu, have you enumerated the commonest?
The overall the prevalence of the adnexal mass in premenopausal women is around 8 to. The commonest is all that is endometrioma, that is 17% to 24.5%, and benign teratoma, that is 10% to almost 11%. Serous adenoma is 11 to 13%, and mucinous cystadenoma is 7 to around 10%.
So we just want to convey this message that these are the benign tumors which are very common and which have got a specific features also. The endometrioma, benign teratoma, serous cyst adenoma, and mucinous cyst adenoma. Few of them have got a biomarkers also. So it is very easy for us to differentiate these, and we should always keep in mind that the range is because it depends upon in which center it is being operated, whether it is being operated in the general hospital or whether it is being operated into the onco center. Next, please. So the next question is, how will you interpret the report of ovarian cyst given by the sonologist, and are there any guidelines to follow up and the counseling? And this question I would like that to be answered by Anju. Dr. Anju?
Very good evening, everyone.
Asna, next, please.
Hello.
Have you understood the question, Anju?
Yeah.
I am not able to hear. Is you muted?
Is it visible? Sorry, I'm audible?
Yes, yes, Anju ma'am, you're audible.
Okay. Good evening, and thank you so much, Asnan, in Lucknow Menopause Society, for giving us this opportunity. And this ovarian mass is, it's every day. It's my 4 or 5 cases we used to do it. So I love to be a panelist in this particular topic. Actually, the ultrasound report, usually patient comes with the ultrasound report to us, and many are of good quality, but many are from periphery and all. So, the things which we used to notice is the size. What are the content? Is it totally cystic or solid contents there? Is it multiloculated? And whether the vascularity is there is minimal, or if it is of good vascular seen over there. So ovarian cyst, as only as a report, we cannot go further. Then further we support these kind of thing with the tumor markers and other parameters. And if you feel any the disease is not localized to the pelvis, we go for upper abdominal disease evaluation as well.
So thank you, Anju. Not only this, that you can see that whether it is certainly benign or is a malignant, we can also see the size and other things which correlate. And there is a Society of Radio Diagnosis, Ultrasound and Green Top guidelines have published the consensus statement also. There are a few spelling mistakes are there. So I'm sorry for that. So it is when you have to operate and when you have to do the surveillance. So it has been said less than 3 centimeter or 3 centimeter is all physiological. 3 to 5, yes. Hello. 3 to 5 centimeters require the follow-up, and 5 to 7 centimeter also require follow-up, but you have to see that whether it is being the reporting is being done by the specialist sonologist and said that it is a certainly benign. It has put the ORATs into the category 2 or 3, or it has been aorta simple features are there. So thank you so much. Next, please.
We must see that this aorta sensitivity and specificity is quite high. It's more than 90%.
Yes. So that is how this is going to be a future probably.
Yeah.
So now the question is, because we often get the non-pathological ovarian cyst in postmenopausal women. Sangeeta, I want your opinion. Dr. Sangeeta, please.
Yeah, ma'am. Thank you so much for the question, and thank you, Lucknow Menopause Society and Yashudra ma'am, to include me in this panel. The moment we see a cyst in a postmenopausal woman, we get alarmed. But most of the time, these cysts are present in the early phase or the early menopause, and they regress as the menopause goes ahead. So these cysts could be non-pathological, and they could be just a sporadic ovulation, or it could be a cyst which is persisting. It could be a physiological cyst which is persisting from the pre-menopausal time, or it could be a small cyst adenomas. And as the menopause progresses, these cysts usually decreases because the estrogen and the progesterone level, it falls. So they could be non-pathological. They could be even a peritoneal inclusion cyst also, which we are considering as the ovarian.
Thank you so much for pointing this. So we at times we hear that the postmenopausal lady got pregnant, and she has because of the sporadic ovulation, and people have been given birth. There is a difference of 20 years or 25 years between the children of some women. So this is the story, and this is the myth. This is the mystery behind it, because there is sporadic ovulation can also occur. Next, please, Asna. So now coming to Dr. Shipra, we hear every time the biomarker, we see everybody is doing the biomarkers, and there's so many panels are there. I am not going into the detail of it. Please be specific also because of the time, and we are not discussing the biomarker. It has got its big panel of itself. So Shipra, can you say that do all premenopausal patients with the ovarian cyst needs these biomarkers? As soon as you see the ovarian cyst, you are going to order all the biomarkers and the panels to see that whether it is a benign or a malignant, or what is the consensus behind it. Asna, please change the slide.
Thank you so much, ma'am, for having me on this panel. And to answer the question, it is not necessary to do biomarker for all tests. If for all ovaries, ovarian cysts, if it is a simple ovarian cyst, then we need not do the biomarker. CA125 is the most commonly widely used biomarker which is available. However, it has its own drawbacks, because especially in premenopausal women, it is not very sensitive and specific. And in women who are younger than 40 years of age group, and if you see any features of complex ovarian masses, these patients, we need to do markers for germ cell tumors, that is the LDH, the alpha fetoprotein, and HCG. This is a recommendation from the RCOG guideline. And there are other biomarkers also available, like the HE4, the CA19.9, and CEA. CEA is basically origin from the colon. So if there is any confusion regarding whether the mass,
next slide,
whether the mass is ovarian or non-ovarian, in those cases, a CEA will help us to differentiate, and a ratio of CA125 to CEA can be done. And if it is more than 25, we can say most confidently that it is an ovarian in origin.
So please change the slide.
So to conclude, those patients who have features of malignancy in like the M features, and who are ORADs 3 or more.
Shipra, we are going to discuss in the next this thing. We don't have to say here only, है ना?
Right.
So you have already said this.
Right.
So the point is this, that the RCOG guidelines, and can we go back? I'm really feeling very handicapped because I'm not able to handle my slides. Okay, fine. So I just want to emphasize that all premenopausal ovarian cysts, unless they have got by iota or by ORATs, some thing suggestive of malignancy, we should not order up even the CA125, because we know what is the CA125. Dr. Shobna has also enumerated in her talk. So it is because sometimes it puts confusion and increases the apprehension. And in the days to day, if what are the litigations we are going through. So that's all for this. Thank you, Shipra. Next, please. Yes. Next, please. Next, please. Asna, next, please. Yes, I am there, but this slide does not change from my side. I go to this. So risk factor for the ovarian cancer, this is Shuchi, would you like to elaborate? And I'll just say that the big table is there. You just emphasize what you are doing in your practice.
Very good evening to all. It has been reported in literature that in general, a woman in her lifetime, she is exposed to a risk of ovarian cancer of approximately 1.3 to 1.4%. And numerous factors have been associated, and that we have also encountered in our clinical practice, that women who are nulliparous or who have a prolonged exposure to estrogen, like if they have an early menarche or late menopause, and especially we have seen recently in a past few years that 2 or 3 cases who have women who are undergoing treatment for infertility, who have undergone treatment for infertility in past or have received ovulation induction drugs. They have come up with ovarian cyst and it have came out to be a borderline tumor. So these are the known risk factor. And beside that, it has been reported that 5 to 10% of ovarian cancer, they have a genetic predisposition. So if a woman is a carrier of BRCA1 or BRCA2 mutation, amongst which BRCA1 is more closely associated with ovarian cancer in 35 to 40% of the cases. And
Shruti, is there anything with the age also in which the BRCA1 is more important and in which the BRCA2 is more important? Is there any age?
Yes, ma'am. BRCA1 is more important in the premenopausal age group.
Yes, when the woman is around 50, it is more
Around
because
50.
we get, in our case, maybe it not because our average age is less for the menopause, but normally it is there, yes.
And then certain inherited syndromes like Lynch syndrome also, they are also associated with increased risk of ovarian cancer. So we need to do a thorough pedigree chart analysis. If a woman has a history, family history of such ovarian malignancy in the siblings, then we have to do a thorough pedigree chart analysis to analyze her future risk of ovarian malignancy. And we have to keep all these factors in mind.
Yes, and plus you should also, it's very easy to, I just want to emphasize here, it's very easy to write the investigations, but it's very difficult to interpret. And if you're not able to interpret it correctly, it will be really difficult. So BRCA1 and BRCA2 and all, so many genetic panels are also available. Now the CA125-2 is also available for the gene MUC1. But you have to learn how to interpret it. That's a very, very important thing, because the people who report, they write so many things, but you have to learn how to read those reports. Thank you so much, Shuchi.
Definitely.
Yes, next, please. So, Dr. Vaishali, coming to you, which are the various non-gynecological masses present as an adnexal mass? Because I'm just put this question, so people should have that it is not necessary that we are the gynecologist and we are going to face only gynecological masses. We get, each question has got a stories with me, but there's no time to discuss all those stories. So I'll just not.
Good evening, ma'am. Good evening, everyone. Actually, this is a very relevant question. Yeah, it is a very relevant question because the adjoining structures near to uterus and adnexa may be misdiagnosed as a adnexal mass, and few conditions which can be misdiagnosed as an ovarian mass can be if a patient has a loaded rectum, like she's suffering from constipation, then appendiceal abscess, diverticular abscess, pelvic abscess, peritoneal abscess, pelvic kidney. They can all be while doing PV examination or while doing ultrasound also. If it is not done by a trained sonologist, then it can be misdiagnosed as an adnexal mass. Some malignant or a malignant neoplasm of bowel or appendix or some metastatic neoplasm can also present as a can mimic as an adnexal mass. So we have to be vigilant and we have to be careful about, and we should keep in mind such options also while we are diagnosing the patient.
So I will just like to emphasize there is an entity of the ovarian abscess and the pelvic abscess. Why I'm saying this? because I've seen pelvic abscess does not have a thick wall. The ovarian abscess has got a thick wall.
Okay,
So when
localized.
you're doing a transvaginal sonography, because of the inflammation, sometimes you can rupture this cyst. Because I've seen while doing this, and the pus has started pouring out from the rectum, from the other places, because they all have got a tissue communications, and I got really panicked what to do. So I just want to emphasize this, that pelvic abscess and the ovarian abscess both could be there, because they present as an acute situation also sometimes. So thank you, Vaishali. Now we have got Dr. Shobna, I may request you to please extend my time, because of we have got the cases also.
Clearnet is generally happy with extending time. I don't think our friends will say anything to you.
Okay, thank you so much. So now coming to the cases, and with this case, because this is the first case and the opening case, so I would like anything other people can also, panelists, although the question is going to Dr. Indu, but other panelists can also budge into this. So the case one is Mrs. A, age 45 years, reports with the complaints of abnormal uterine bleeding, dull pain, and pressure on the left lower quadrant. Vitals are normal. Case of no family history of, this case has got no family history of breast or ovarian cancer in first degree relative. She has no idea about of any illness in the second or the third degree relatives, as always happens. And her next, please, her previous findings are as follows. So Dr. Indu, would you like to throw some light on this finding? What is these findings show, and whether it is going to help us in making some diagnosis or not?
Yes, ma'am. Actually, these sonographic findings are showing the benign features of the ovarian mass lesion. Like there is International Ovarian Tumor Analysis Simple Rule, by which we can categorize the malignant and
Can you
benign.
say what are the simple rules?
Okay, in benign features, the ovarian cyst should be smooth wall with anechoic shadow, or it could be smooth wall cyst without any solid lesion, or solid lesion less than 7 millimeter, or there could be a multilocular cyst with smooth wall, and the largest cyst should be less than 10 millimeter. Or there could be a acoustic shadow due to this ovarian mass lesion, and absence of these signals, color signals on color Doppler. So these features are called the benign features, which has been categorized from B1 to B5. And in my case, the first case, which is most likely is a case of simple ovarian cyst, which is in that case, because a patient is premenopausal and there is history of abnormal uterine bleeding, which could be due to some ovulatory dysfunction uh, anovulation, which can lead to the thickening of endometrium, and which leads to this abnormal uterine bleeding. And these can lead to, this anovulation can lead to the formation of simple cyst. And in my case, most probably the diagnosis is this simple or simple ovarian cyst, or we can call it physiological cyst.
Asna, can you go back to the previous slide, please? Yes. So I just want to say, what is this? Anybody from the panelists, what shadow you are seeing looking this? Because this picture is anechoic simple cyst. The size is not being mentioned here, but we are going to mention in the others how we have to decide whether it is needs a surveillance, or it is needs the expectant management or the surgery. So what is this? I just want to know from the other panelists, what shadow is this? This is the acoustic shadowing.
Shadow.
Yeah, this is the main feature of the simple rules of the iota, because this is very important. It says that even you are getting the transmission from the fat which is behind it, this ensures that it is a thin walled cyst. So acoustic shadowing is going to emphasize that it is a benign cyst, because it is able to cast a shadow of things which are behind the ovary. Thank you so much. The rest everybody knows. How you are going to approach this case? Can you classify which aorta is there and what is this thing, Indu? What ORATs it fits in?
To approach like this case, we will go by the first of all, by the history of the patient, in which we will ask about the menstrual history and about the duration of cycle, duration of bleeding during menses. Is it associated with any pain, dysmenorrhea, or along with the obstetric history that patient is nulliparous or
Next,
it is multiparous. And we can ask about the breast and other genital cancer in their family, or then we will go after this history on the examination. And in physical examination, we will go by stepwise, like general examination. In general examination, we can see for any pale, if patient is giving history of abdominal uterine bleeding, then we can see for any pallor or in presence of any thyromegaly to see any hormonal imbalance. And in systemic examination, we will examine the all system and the parabdominal, perispeculum, and pervaginal examination. In parabdomen, if the cyst is enlarged enough that it can be palpated through the abdominal wall, and in perispeculum examination, we can see any cervical pathology, or we can take the pap smear if the cervix is not healthy along with the examination. And in bimanual examination, we can palpate the cyst. We can see the size, the mobility, and the consistency of the cyst, that it is benign, or we can palpate some solid component of the cyst also. So we can differentiate by pervaginal examination to some extent.
Asna, can you change? Yes.
So this is
she has already enumerated. Now can you change again?
Yes. So these are the same B feature findings, that is unilocular cyst of any size and with or without solid component, and solid component should be less than 7 millimeter in these cysts. Presence of acoustic shadowing, smooth multilocular cyst with larger cyst less than 10 centimeter. And there
be
should be
specific,
no
Indu, be specific that what are the iota score in this is a benign feature. You have rightly pointed out. Asna, please change the slide. Please change the slide. Yes. And so what is it? ORATs.
ORATs is a ovarian adnexal
what is the score in this? We know that it is
in this case, the scoring is 2, which is known as almost certainly benign pathology, benign ovarian cyst, and the risk of malignancy is less than 1% in these cases. And if the patient is premenopausal and up to 5 centimeter, we have to do nothing for these patients. And if the cyst is more than 5 centimeter but less than 10 centimeter, then we have to repeat her transvaginal ultrasonography after 8 or 12 weeks, 8 to 12 weeks.
Next, please. Asna, please change. Yes, there are few images are there. If promptly you can say that what are these, because they are the one why these are being put, because the ORAT says there are simple, it has correlated. In the next slide, I will show you what is happening. Can you go to next 2 slides, Asna? Next. Yes, it says that there is some cysts which have got a specific features. Classic benign cyst which has got a classic features. So if we can have these cysts, please go back to the other slides. Back. Yes. So these are the cysts which we have to see that it is not a daughter cyst is there, which is being presented here as a septa. So this cannot be reported by an ordinary sonologist. It has to go to this thing, a specialist sonologist. Same way here we can see there is a solid tumor, and there is a, you can see there is some internal Doppler color flow is also there. And so fireball like a picture. But this is a corpus luteum. So whenever you are in doubt, before operating, I know that this happens, and sometimes people have operated in pregnancy and removed the corpus luteum. So it should be sent to a specialist gynecologist. So next, please, Asna. So this picture, anybody can say what is this picture shows? Because this is also showing some septa or something. It may confuse with some malignant
It's a
features.
hemorrhagic cyst. It is a hemorrhagic cyst.
Spiderweb pattern is there.
It is a fishnet appearance.
The reticular pattern is there.
Yes, fishnet appearance.
Yeah,
Thank you,
it could
Sangeeta.
be in the corpus luteum also and the simple cyst also.
Any hemorrhagic cyst, It could be in the premenopausal and age group also. It is presenting, and it transition. It makes a panic. I know many people who have come to me and then how we have managed. So, but nothing doing like this here. So here is the another picture which
The
shows
ground glass appearance in the endometrioma.
And
and there is no color flow. The color scoring is hardly 1 or 2. 1.
Yes. And this one?
This is a fibroid which is pedunculated, and here if you
no, I'm talking about the other. You are talking about this, okay? You can talk about this only. Pedunculated fibroid.
Here, if we put the color flow, we can see the blood vessel going into the pedunculated fibroid.
Yes, I've operated this also in a pregnant woman of 25 years. My God, daughter of some scientist, and she herself was a scientist. How we could save her life, I only know. So, and what is about this?
This is a dermoid cyst, ma'am, and here you can see the sebum which is in the supernatant.
What is this? The yellow arrow which is pointing out?
These are the hair tufts. Hair tufts.
Yeah. Thank you so much. Next, please. Yes. Anybody else besides Sangeeta can see that what are this, because this is a longitudinal view of this thing of a picture.
This is a picture of hydrosalpinx, dilated tube, fallopian tube, that is hydrosalpinx.
Yes. So you see, you have to see this not only in a this is a difficult diagnosis on sonography. So you have to see in a longitudinal view, you have to see in a transverse view, and then you see there is a septa, because the cogwheel appearance comes only in the transverse view, not in the longitudinal view. Although here you can see there is a septa is there, but I am not able to see this transverse view here. So, but what you can do a tomographic assessment of this also. So all these things needs a little higher sonologist who can comment on all these things. And then you can see these sections of 5 millimeter is been cut. You can see whole of the cavity here. And you can see these are the septa. These are the septa there. And then 3D can also...
Ma'am, the classical sign which we see in a hydrosalpinx is incomplete septa. The tube will be distended and we'll see incomplete septa, which will give the cogwheel appearance.
Yes, but it could be into the ovarian also. Yeah. So you have to see in a transverse, you have to see in a longitudinal section. Sometimes you have to do the sections, and sometimes 3D is only helpful in cases of hydrosalpinx. If you really want to be sure that it is a hydrosalpinx, especially in case of those who are practicing infertility, whether they have to remove, they have to clip, or whatever they have to do. So then this is necessary. You do a 3D for this. Next, please, Asna. So this is how this OVATs and the features were fitting into it. This simple ovarian cyst of 5 to 10 centimeter. If it is less than that, you don't have to do anything in the premenopausal state. But in the postmenopausal state, you can follow up for a year, every 3 months, and then every yearly for the 5 years you have to follow up these cases for the surveillance. Because many women are very high risk for the surgery. And I know that the same thing as happened in the Noida, before putting the incision, the patient had the complication and I was in soup, but definitely because I did not put incision, so I was saved from that case. So it is because these are old age women and you cannot investigate them so thoroughly that you can avoid everything, every mishap on the OT. And if it is less than 5 centimeter, you just have to, here there is some difference between the green top guidelines and the American OBGYN, because ACOG, some say it has to be done only at 3 months, some says it has to be repeated at 8 weeks and 12 weeks. And then if it is subsided, it's all right. Otherwise, you can repeat after 6 months also. If the cyst is static, it is decreasing in size, or it is static, or you do not see any other feature which has come up. And two, we have seen that all the categories is specific, because we will come to the four steps of the stratification of the diagnosis. But before that, I just want to emphasize here that it is a cyst which has got specific features one has to do into this. And why the panel is being done under 40 years of the alpha fetoprotein, because germ cells are more common, tumors into, and the tumors and the malignant transformation is more common in the younger age group. So it is under 40, you have to do all those panels. Thank you so much. Next, please, Dr. Asna. So anybody can say opinion regarding the CA125 in these cases. A is written small, it should be big. So please excuse me for that. Anybody? Next, please. Asna, you can change the slide. Yes. Anybody would like to say?
Ma'am, actually, she's a premenopausal woman and ORETs 2 benign pathology. So CA125 doesn't hold much of a value, because it is a non-specific marker, and because it is raised in certain other conditions also. A lot of other conditions overlap in which CA125 is raised. So it is not very necessarily to do CA125. We can follow her up with a repeat sonological scan.
Yes. So unless she has got a high risk factor, we should know, because high risk factor we are not discussing here. It needs a separate monitoring, separate guidelines for the monitoring of the high risk cases. So we are talking about the average risk woman or the low risk woman who has come with this. So please mind it, all these, whatever we are talking today is not for the high risk cases. It is only for the average risk or the low risk woman. Next, please. So in the previous case, we just concluded saying that we have to learn the IOTA, we have to learn the ORATs, and we have to learn the risk factors. And in that view, we have to see that what we have to do, whether we want to have expectant management or the surveillance or the surgical management. So much detailing can be done only on one case, but we have to do the other cases also. So my second case is Mrs. X, the age, and this is a 64 years, probably here is the age which is missing. And she has got a menopause 5 years back, 56 probably. Reports with the complaints of dull pain and pressure on the left lower quadrant. Vitals are normal. Known case of type 2 diabetes mellitus, hypertension, controlled on oral medication, and a tedious finding. Next, please. Are almost the same, but there's something is being given differently. So anybody can point out what is different in this case, which is showing, or is mentioned here?
Size of cyst.
Yeah, because we have not specifically said that size is 7 centimeter. It's a multilocular cyst. There's a solid component is also present. And the color score is 1, 2, 3, because she's a postmenopausal patient. All postmenopausal patients with ovarian masses, they should be, there's a recommendation from ACOG, they all should go, should have the at least CA125 for the follow-up, although it is not a very good marker, but still to know and to follow up, because they all need surveillance on the postmenopausal patients. So we need to have a CA125. So when we need a surveillance, we do a surveillance by CA125 and with the sonography. Next, please. So how to approach this case? This case is for Dr. Anju. Dr. Anju, you have been invited because you are the one who is doing a very good job on WhatsApp. I keep on seeing you are operating big cases.
Actually, here CA120, can you see the previous, how much it is, the CA125 level?
Less than 35.
Okay. As such, CA125 is not very specific in early ovarian cancer. Approximately 50% of cases, you won't get high CA125. Even there is a cancer in the ovary. So we should not rely on that only. But of course, we have to do all the routine investigations like CBC. Since she's a diabetic patient, we have to look for her blood sugar, RFT, LFT, thyroid profile, mammography, and of course cervical pathology, cytology.
Yeah, this is a window of opportunity because she has come to us, so we have to do the full screening for the case and for the menopausal status also. Yes, next please. So we should never forget a window of opportunity in all patients who are coming to us, and we do all available tests for them.
Yes. And the tumor marker or biomarker in this age group, we should definitely include CEA. 19.9 is, of course, we used to give it, but it is not very much specific for ovarian cancer. HE4 is very, it's good, but again, with the increasing age, it is not very sensitive. LDH, alpha fetoprotein, and beta HCG in this age group, I don't think indicate much help. So in this age group, CEA 19.9 and 125 is good enough.
I just want to know, Anju, in this case, whether it is needed or not.
No, ma'am. She is a postmenopausal lady. In postmenopausal lady, I mean, if you can do, you can do. But in this age group, for further evaluation to differentiate whether it is an ovarian or malignancy, it is CA125 and CEA 19.9 is good enough. Not more than that needed here.
I will say it is only 125 because the mucinous cyst has to be the specific marker for that is CA 19.9. CA is for the follow-up of the management probably. So, or you can get this thing, but because your cyst is a unilocular cyst, it is anechoic. So it doesn't say that it is a mucinous cyst. So I'll say CA125 is good enough. And the recommendation of ACOG is only for CA125 only. So because these are expensive tests. So all of you, I am sure that you will agree. But of course, because here there's no protocols, you can do it anything. But ideally is this. The protocol says only this. So Anju, thank you. Because we are more apprehensive. So we always try to do as much as possible for a woman who is coming in the postmenopausal. So I agree with you also. So because she is a case of postmenopausal woman, you have written, but you have not emphasized over the color score because the ORATs emphasize a lot on the color score.
Yes, the Shaijism, Lakshmi, Jyoti Muri Samsarcha,
Host, please mute everyone. Host, please mute everyone. Host, please mute everyone. Anju,
color score is very important. Is very important to differentiate between benign and malignant ovarian. So here color score is 4. So it is quite significant.
3.
A good speaker.
It's 3.
Yeah.
So 3 is
you and Jyoti are good speakers. That's attractive.
If it is a score is grade 4,
second
then it is going to be intermediate risk. If it is going to be color score 1, 2, 3, it is going to be the low risk. But if it is going to be less than that, probably it is going to be certainly benign. So this is how you go through this, and then you decide the surveillance with ultrasound and CA125, follow up every 3 months for 1 year, and then for 6 months, and then yearly for the 5 years. That is how the recommendation is to follow these cases. First you do the aorta, then you do a ORATs, and then you decide whether it is a high risk, whether it is a intermediate risk, or whether it is a low risk. And then you have to decide about how you are going to follow up. Good. Very nice. Next, please. Host, please. Shobna, can you mute yourself? Thank you so much. Anju? would you like to throw some light over this 4-step strategy for risk assessment? What is this? Because very new. How to go and stratify the risk.
Not very aware.
Not very aware. Doesn't matter. So it is a new one which has come up because it is a 2-step strategy is being devised by the IOTA people, but OVATS has done a 4-stage. So first thing you have to decide whether it is a simple cyst or it is not a simple cyst. So in all pre and post-menopausal patient, the cyst more than 3, but less than 10 are almost certainly benign, and it comes under the scope of OVATS 2. Step 2 is the findings are consistent with another physiological process we have shown in the other slides, whether it is a corpus luteum, hemorrhagic cyst, benign endometrioma, or the dermoid cyst. So if it comes into this, again, it becomes a OVATS 2. You don't have to, you do specific management for these which has got a consistent with another physiological process is a corpus luteum and hemorrhagic cyst. And step 3 is, I will repeat it again. Step 1 is a simple cyst. So in pre and post menopausal patient, if it is less than 3, but more than 3, but less than 10, they are almost certainly benign if it comes under the OVATS 2 and the benign B features of the aorta is present. Step 2 is the findings are consistent with another physiological process. They are of any size, like corpus luteum or the hemorrhagic cyst. They could be present in the mostly present in the premenopausal patient, but sometimes they can present in the transition period or in the postmenopausal also. So this is how you decide. They also comes into the OVATS 1. Step 3 is whether the findings are consistent with the specific pathology, like the endometrioma, dermoid, pedunculated leiomyoma, hydrocypings, and other features, peritoneal inclusion cysts, and so many things are there. So if it is there, you have to do the treatment according to whatever the treatment is being designated for these pathologies, endometrioma or dermoid or the pedunculated leiomyoma or the hydrocypings. Step 4 is very important because only if you have done this, you will see that it does not fit into the 1 and 2. So whether these findings I am able to interpret or I need an additional evaluation by the gynae oncologist, and I need a further imaging, because it is better to send it to gynae oncology who will decide what to do, or otherwise if we are experienced enough, because this is a transition time, we have done so much cancer. So I feel that people who are doing for last 10 or 20 years, they are also good enough as a gynae oncologist. So whether you need these cysts has to be reevaluated by the sonology specialist or by MRI to see whether the OVATS is going up or going down. So this is the step 4 is very important to be sure that it is a certainly benign or it is towards the malignancy. It is having some features of the malignancy. So we can have the follow-up. So this is how we have to go for the follow-up. This flowchart, I'm not going into it. Everybody can read it. Next, please. So this is what is the ACOG consensus statement for premenopausal I've read there. And in the postmenopausal, CA125 is done in each and every case. And they have preferred to do a surveillance for these things. Next, please. So coming to the case 3, is a 30-year-old. So what we have learned from the case 2, we have learned from the case 2 is that features we have seen that is the same in both the cases, but because of the age, the risk differed. And because of the color scoring, the risk differed. And so we had to follow the different pattern, and we have to see, we have seen that it is although it is having a OVATS 2 only, but still we have to see, because there's a menopausal status, we have to do a CA125, and if it comes elevated, whether we would like to this case to be seen by a sonologist, specialist sonologist or the MRI, to see that whether it is OVATS upgrades or it doesn't upgrade. If it doesn't upgrade, we can go for the surveillance. If it upgrades, we do accordingly. So that is what we have learned from the case 2. Anju, you agree?
Yes, ma'am. Perfectly.
Or you want to add something?
No, ma'am, it's fine.
Okay, thank you. So coming to the case 3, that's a 30-year-old woman, Gravida 2, Para 2, having a cyclic.
Yashodhara, you may have to hurry because the time is getting
I'm
over.
having, yes, I know. I am looking at my watch. I have just kept it in front of me. And
Just hardly 10 minutes are left.
I thought it is 1 hour. It is 1 hour, exactly 1 hour has completed. Because we have handed over at 9, some whatever your time is. My time is 9:40. Yes. So case 3, it goes to Dr. Vaishali. Dr. Vaishali, would you like to throw some light on it?
Yeah, it is a Para 2 patient, 33-year-old. She is presenting with a cyclical pelvic pain and premenstrual spotting. So we and a palpable firm mass in right adnexa. We have a differential diagnosis of a. Okay, ma'am, this is her ultrasound.
Yes.
Yeah, this ultrasound, it has a ground glass appearance with a low homogeneous, low internal echoes. So and a peripheral slight blood flow. So it's looks like an endometrioma, which is a very common benign neoplasm present in a reproductive age woman. So
yes.
As per IOTA and ORAT score is because it's an endometrioma, it is because of the specific pathology, and the IOTA score is a B features because it is a unilocular, and color flow is on periphery and no central flow, and there are no septas and no solid components. So it is IOTA B feature and ORATs is 2.
So what do you say? It is a benign?
Yeah, ma'am, it is a benign because all the features are IOTA and ORATs are suggestive of benign features. And it has been found that there are only 1% chances of endometrioma converting into an malignant cells, and that too if it has a more size of more than 9 centimeter, or it is of age more than 45 years of age. And as per
we conclude, Vaishali, that we can say certainly it is a benign mass.
Yeah.
By the features, because the color you can see, it is only at the periphery, it is not at the center. So color score is also 1 only. Yeah. So I will skip the pathophysiology because this is not the question for this panel. So I will say, what would you like to estimate the CA125 into this if you would like? So what are the things you would keep in mind?
Ma'am, actually, as we have discussed throughout the panel, that CA125 has little role, especially if we are finding benign features, and those moreover, she's a 33 years old woman. So I won't think CA125 is of any help in this patient. And besides endometrioma and epithelial ovarian tumors, it is positive in various other inflammatory pathologies also. So it is a non-specific marker, and I would not like to go for this in this case.
But would you like to make any comment whether it is important for the follow-up of the management of the endometrioma?
Ma'am, I think in practical approach, I think CA125 doesn't help in management also.
Ma'am, I'd like to differ.
If you do a conservative management, if you do a medical management, it decreases with the management.
Yeah, ma'am, it decreases, but it doesn't affect our approach to our treatment.
Yes,
definitely we can monitor it, but it is not leading the path for a treatment. Whether we should, if the CA125 is the same or increasing, then we have to operate. It doesn't, we doesn't decide our treatment on the basis of CA125.
I agree, but because of the patients who have the Google, who consult all the time Google doctor, they keep on saying, "Madam, my CA125 is this, and this thing is I am having a malignancy and this and that."
So we can do a baseline CA125 and then
so they come only with the baseline.
Yeah.
If somebody has got it done,
Yeah,
if it is not, then it is all right. Otherwise, you have to do and repeat and show them that it is decreasing and so you don't have to bother.
Yeah,
But if it does not decrease, then you are again in the soup. You have to do a lot of counseling to do. Next, please.
It is little.
Asna, next, please.
So the malignant transformation is
You have
around,
already said that it is a 1% chance of going into this. So I am again not going into the medical management also, but I'll just say, would you just say that when you have to do a surgery in these cases?
ma'am, usually surgery is when a patient
Asna,
is
next, please.
surgery depends upon whether the patient is symptomatic, or if the mass is more than 5 centimeter and she's desirous of pregnancy. Otherwise, if the size is less than 5 centimeter, even if the patient is infertile,
Next,
we are
please,
not going for
Asna.
surgery.
Yes, next, please. So coming to thank you, Vaishali, that we have learned that we have to see the specific feature, and those pathologies have got a specific management also for those. So you have to see that if you are confident that it has got a only because the specific feature, you don't have to send it to the specialist. But if you are in doubt, you can send it to the specialist sonologist and manage accordingly. And biomarker, we all know that we have done it along about the CA125, so we don't want to repeat it. So now coming to the last of my case, the next 2 cases will be done by Dr. Nani. So this case is 64 years old woman. There's a postmenopausal woman who is coming with the abdominal symptoms, and her Asna, can you go to the slides? The findings are cyst size is 7 centimeters, septum is thick, and there's a papillary structures which is more than 7 millimeter in size. The color flow you can see. So next, please, Asna. So what is the interpretation ORATs and aorta again? Because we are emphasizing only in this panel about the aorta and ORATs. And on these basis, we are managing all these patients. So Shuchi, please.
Yes, ma'am, I'm seeing the age of the patient and seeing the ultrasound picture. It seems a pathological cyst. And if we score according to the ORATs, then it will come. It will have a high score. I will score it as a 5. ORATs 5, and by aorta it is by M rules. It appears to be a malignant cyst. So seeing the age of the patient, I would like to further take the history, whether it was rapid in onset and whether it is a short duration history. Then I would like to have a further repeat. I would like to have a repeat scan to look for abdominal cavity also, whether the tumor is confined to the pelvis or there is extra pelvic spread to the other organs. So I would like to have an CECT abdomen pelvis done and have to look for the findings of it. And then apart from
let me talk about whether you would like to get a CT done or whether you would like to do the MRI.
Ma'am, I would like to prefer to go for CECT, because in CECT we have a better assessment for the lymph nodal status, about the spread to the lymph nodes, and about the any omental nodules, any omental caking, and about the visceral spread. So CECT, I think, is more sensitive in such cases.
So I will suggest that you have to do a CACT and plus MRI also, because for the findings, MRI is better in the ovarian masses than CT scan. Do you agree? But for seeing the lymph node and for seeing the taking of momentum and all those things, you need a CACT.
Yes, ma'am. And then we will go for, definitely we'll go for the panel of the tumor markers, epithelial, to look for the epithelial origin of the tumor. And after ascertaining it is a malignant tumor and seeing the age, then we will proceed on for the upfront primary debulking surgery. And later on, based on the histopath report, followed by post-adjuvant chemotherapy.
So yes, there is a debate again whether you would like to do a new adjuvant and then you are going to do a surgery if the waiting is there, or you would like directly, because I am not going to do this because it is not in this panel. So you have already enumerated this. Factors decide the surgical exploration. Next, please.
Factors are depending upon.
You have already said that. You have already said M features. So this is how the flow chart goes for the postmenopausal patient with the adnexal. So would you like to do it yourself? You are a gynae oncologist. I will take you as a gynae oncologist, gynae onco. But still, I just want for the audience would you like to enumerate what are the indications referring to the gyno? Because everybody is not a gyno-onco.
Ma'am, if we suspect it is a high-grade malignancy and it has a spread outside the pelvis with high CA-125 levels and associated ascites, or the evidence of a spread into the peritoneum and nodules and evidence of distant metastasis to other abdominal organ. So it is better we refer to a gynae-oncologist who is more competent to deal with such a difficult cases, so that in the first go, we have a completion surgery and we leave a R0. We come out with a residual 0. So it is good if an experienced person deals such case, so that in the first go, patient has a complete extirpation of the disease and she is cleared of the maximum bulk of the disease. That will help her in the later run and will make it more chemosensitive, and she will have a better survival outcome, 5-year survival rate.
So will you agree if I say that the malignant ovarian tumors operated by the gynae-onco and operated by the operated by gynae-onco has got a better survival rates?
Definitely, ma'am, because routine gynecologists, they don't do very radical surgery, like they don't do peritonectomy. Like in such cases with disseminated disease with peritoneal involvement, we need to do peritonectomy, and we have to at the time sacrifice the bowel if the bowel involvement is there, and we have to at the time we have to do specific resection of the involved organ. So that we are not very competent. Being a general gynecologist, it is difficult for us to go for such an advanced surgery. So at the time,
or you ask a surgical oncologist, you can also call with you, because you are a gynae, and if you call a surgeon, because gynae-onco is very few. So you can call a surgical oncologist also, and along with that, you can also operate. Do you agree?
Yes, definitely, ma'am. Survival outcome is definitely improved with a good amount of the removal of the residual tumor.
So I just put a slide because I may not get a chance. But Nani, you are welcome to take the next two cases.
Ma'am, I think there is no time now.
Yes,
for the
yes,
next
please,
one.
by the kind permission of the remaining two panelists. No, ma'am, suniye. With the with the permission of the remaining two panelists, Sangeeta and Shipra, we are definitely running behind time, so we can take those two for some
Nani,
other day.
we are running behind only by 7 minutes.
20 minutes.
No,
and
it is supposed to finish. It's supposed to finish at 9:30.
Sorry, madam, the webinar time is between 6 and 8.
Ma'am, keep the topics for some other day.
Okay, fine. If all of you agree, then it is all right. Otherwise, I am feeling bad.
Is it all right with you?
Because they are short cases, and Shobna, they are short cases. They will
so it's
go.
It's not me, Prachi and Para. Can you allow 10 minutes for the two questions?
Yes.
I'm not the persons involved, because
Yes,
we have been given the time
cases.
between.
They are short
cases. Short cases or long cases, but our partners clearly have to agree. They have been given time of 6 to 8, and probably it is 8:30 now. So we have finished overshot the time they've given us by half an hour.
It is 10 minutes are left.
To 8:30, in India, it is 8:30 now. It is 8:25 now.
Keep it for some other day,
will you give us 10 minutes more?
Yeah, 10 minutes, because they're short cases.
No, let me ask them. Are you there? Clearnit?
Hello.
Can you give Lucknow Society 10 minutes more? It's up to you.
We can wind up 8:30, ma'am. 5 minutes we can try to come up. 8:30 we will be closed.
We cooperate with for the 10 minutes, ClearNet people. You are doing so much.
I am sharing my screen. I am sharing my screen.
Menopause is doing so much with the ClearNet. I'm sure that it is going to be.
Can you see
for last 2 years, the ClearNet has been used by the IMS.
Yes, Dr. Nani, we can see.
Already we have.
This I have kept a case. This is for you, Sangeeta.
Yeah,
this
yeah.
is a case of
put it on full screen. Please put it on full screen. Anyways, the patient is for a perimenopausal. She's 42 years old, and she has some abdominal pain, which is more towards the right side of the abdomen. There's no evidence of ascites. And on a pervaginal examination, there's an adnexal mass, which is in the right and the posterior fornix. The size is
The size is 9 into 9 into 8 centimeter.
Yeah.
So, Sangeeta, let us come to this is a mature cystic teratoma.
Yes.
And let us come to the ultrasound findings of this teratoma. And if any two findings out of 4 are present, we can say with 100% confidence then that this is a teratoma on ultrasound and we don't need any other investigation. So kindly enumerate the 4 findings.
So the classical symptoms which we see, the classical signs which we see on the ultrasound is the commonly we see a Rokitansky's nodule, and this is a echogenic protuberance which is towards the cyst. This is the most common of all, and most of the malignant transformations they occur in this Rokitansky's nodule also. And then we see the tip of the iceberg sign, and here the tip of the iceberg sign, and again it is pathognomonic of a dermoid cyst, and here there is a echogenic area which is in the rear view of the ultrasound, and there is a acoustic shadowing on the in the posterior half in the posterior part of the cyst.
Dr. Neni, your slides are not moving. Your slides are not moving. You're on the first slide. No.
Yeah, not moving, nor we can see the full screen.
Please make it full screen. Go on slideshow. Go on slideshow at the bottom.
We can see the icon where you can put it on slideshow. And this tip of iceberg
sign. Put it on the slideshow.
No, I think you just discuss the case and forget the slides now because it's already 8:30.
So this is what will be the management in this?
But your slides are not moving.
Forget the slides, I'm telling you.
For the management, we can decide whether we have to do it laparoscopically or we do it by laparotomy. Ideally, it would be by laparoscopy. The gold standard is by laparoscopy because we have clear diagnosis of a dermoisis, which is having all the B rules or the B signs, and it is completely a benign tumor. And but few things we have to be very, very careful of, that the cyst should not rupture during the surgery. When we are doing it either laparoscopically or by laparotomy, and the tissue retrieval should be done in a endo bag. We can even use a double endo bag. The tissue should be retrieved by the umbilical port, or we can even take an accessory port, no problem. And if by any means the cyst gets ruptured in the abdomen, then we should put the patient on continuous copious irrigation, which should be done via warm fluid, because in the warm fluid the sebaceous material will get dissolved and the patient will also not have hypothermia because of the excessive fluid irrigation.
Thank you, Sangeeta. And now the last case goes to Dr. Chipra. This is a case of benign serous cyst adenoma. So what will be your management, Dr. Chipra? Can you see the slide now?
Yes.
What will be your management?
The management for benign serous cyst adenoma is basically you need to do surgery. So if it's a young patient, you can go in for a cystectomy. Otherwise, for an older patient, you can go in for, especially a postmenopausal patient, hysterectomy with bilateral salpingo-oophorectomy. But before that, you need to do, characterize the ovarian mass, you need to do CA-125, and only then you can reach to a diagnosis of whether it's a benign or a malignant cyst.
Thank you, Dr. Chipra and Dr. Shobna Mohandas. That is all. We have completed our panel. And
thank you so much. Thank you, Nani, and I'm sorry for
no, ma'am, it's all right. It's all right. So I thank all the esteemed panelists for taking out time and participating in this discussion.
Stop sharing.
Okay, ma'am. Just a
Thank
second.
you. So I just want to thank Shobna, and I'm sorry that we took little long, but ovarian tumors, you just cannot finish without 1 hour. So either one case is being distributed to all, it takes much more time. So I thought it should be one case should be discussed with one person only.
Okay, we have done a great job, and we've got a lot of information from the panel.
I'm so thankful to
on behalf of Lucknow
and to everyone,
Menopause
all the
Society, on behalf of Lucknow Menopause Society, I, Dr. Amrit Gupta, thank you all for a very informative session, and I extend thanks to our President, Madam Shobna for starting this series of very informative sessions, and also Dr. Yashodhara Pradeep for taking up this challenge and putting a topic of very great importance to all of us. And also I thank all participants or panelists, speakers for such a wonderful session. And I would fail if I don't thank the participants and the participants who had made this program a success, and also to Mr. Farzan and his team for hosting this event for us. So time being short, I would just put the screen on a group mode to take a screenshot so that we can have the remembrance of this.
Yes.
Thank you all.
Thank you. Thank you. Thank you, Doctor.
Thank you.
Bye, ma'am. Thank you.
Bye, ma'am. Thank you.
Thank you so much, everyone.
Thank you, everybody.
Thank you so
Thank
much,
you.
ma'am. With all your
Thank you,
permission,
ma'am.
ma'am, we are closing here, ma'am.
Yeah.
Thank you so much, Shobna, ma'am. Thank you, everyone.
Thank you, Cleanit, for being with us every week.
Okay,
Thank you,
ma'am.
Shobna ma'am. Thank you, Reena ma'am.
Thank
Good
you.
night,
Bye.
everyone. Take
Nice
care.
panel.
Thank you. Thank you, Dr. Seema.